This is Selma Schimmel, and this is Unique and Unmistakable Amsterdam. The cultural and commercial capital of the Netherlands is used to being the center of attention, and this year is no exception as it hosts the European Cancer Congress 2013. This is a multidisciplinary cancer congress sponsored by ECHO, the European Cancer Organization, ESMO, the European Society for Medical Oncology, and ESTRO, the European Society for Therapeutic Radiology and Oncology. Bringing together the most imaginative and innovative minds and researchers from across the continent and around the world to engage global stakeholders, coordinate a unified oncology community, and speak with one voice. Vital Options Advocacy in Action is here to do the same, bringing together influential leaders of the cancer advocacy community for a three-part advocate forum. This is our fourth European Advocacy in Action, and we are so proud to be in Amsterdam, grateful to be partnering with ESMO and ECHO, and honored to bring it to you. The oncology nurse probably has more time to spend with the patient and really is not only the supportive arm to the physician, but most importantly is the greatest support arm for the patient. And maybe you can expand a little bit, because I realize that as you wrote me, that you feel that patients don't even realize how powerful a role their oncology nurse can play. So let's focus a bit on what you can do to enhance compliance and adherence.
I think not only what we can do, Selma, but I think as a European oncology nurse, or all of our whole society, we have to realize that there are 28 European nations. Each of them have their own disparities, their unregular forms of therapy prescribing. They have a diversity of cultures, of everything. And so if one puts it all into one package, I think it's not the real world. Now, I think you can take two situations. You can take the real world, or you can take what we would love to have. And I think from the side of the oncology nurse, and you put that really very well, the patients do tell us much more than they tell the physician, because they're afraid often that the physician will say, well, we'll stop the therapy, and therefore, or switch or whatever. So I think from the side from the oncology nurse, and I talk from adherence, not compliance, because compliance has an element of, I tell you, you obey. Mm-hmm. The adherence is, we're going to make a deal, and if you would like to take it, then let's see if we can help you do this. So I'm going to use the word adherence instead of compliance. And I think as a nurse, we have a major role in the real world. After the physician writes his prescription for an oral drug, the patient has the prescription. It's very often that the patient goes out of the clinic or practice, goes to the pharmacist, fills the prescription, and has no real idea what's ahead, or what they expect, or what they should expect. So our crucial point, or in the, let's say, patient pathway from oral drugs, and oral drugs have been on the market since 1950. This is nothing new. It's just increased exponentially with the new targeted therapies, is that the nurse should be second line in the information chain from the physician, who is the, and rightfully so, the original information giver, the prescription giver, unless there are nurse prescribers, which is very seldom in Europe on the whole. And then the nurse can assess in a short time, actually, how is this patient going to adhere to the therapy by using open questions, or what one calls motivational interviewing, by asking, if the patient even understands what they're supposed to do with the drug now that they have the prescription. And it's very, very often in clinical practice that my patients will say, I don't really remember what the doctor told me. And so it's that second line, not of therapy, but of information, with proper information, written information, along with verbal and explanations of questions. Do you understand this? Would you like me to help you with this? Where do you see problems taking this tablet? Now, if one can just digress for a short moment, the patient's age group, we have a sort of a bell curve, which goes like this. And the major part of the patients are in the middle of middle-aged. We have, though, many more older patients. Our patients are getting older, the population is getting older, who have multi-morbidities. They have 15 tablets to take a day for every possible illness under the sun. Each one looks a little bit different but the same. So there are 4 white ones and 3 pink ones and 2 brown ones, and they don't really know how to take what when. There's drug-drug interactions, there are food interactions, there is morning, evening, double. We have to explain that to them before they leave the clinic or the practice. And this is where the nurse can play a major role to help the physician who has given the first information, correctly so, but can really support the patient also, as you say, possibly with a telephone triage if the nurse has the capability, the competence, and the time to call the patient after a couple of days to say, are you having any troubles? Tell me, what are you having trouble with? So I think there's a major possibility for nurses to do things in the real world in short time. It doesn't take more than 5 minutes to interview a patient properly. And then we see where some of the problems might come that the patient neither tells the physician nor admits to themselves.
Thank you, Dr. Enyu, Jan Geisler, and Anita Margulies for being part of this interactive panel.
Welcome. Thank you.
Thank you.